In the meantime, we have a different kind of movie of sorts to present to you, a comedy. So let me present to you from the great Commonwealth of Massachusetts, Dr. Amy Linsky, general internist, associate professor at Boston University and the VA Boston Healthcare System, comedian extraordinaire, Dr. Chris Zimmerman, associate professor of pharmacy at Virginia Commonwealth University, director of the Congressional Health Policy Fellowship Program, comedian extraordinaire. Take it away.
And thank you so much to Mike and Cynthia for the invitation to come back and present this year's rendition of Updates in Deprescribing Research. Now, keeping with tradition, Amy and I have a theme again this year, and it's pretty consistent with our sort of stay here in Chicago, and that's wise guys and wiser prescribers. So neither Amy nor I have any disclosures to share, and the views we express are ours and not reflective of our respective employers. I do want to also note that many of the study authors that we'll talk about today are here in the room. I apologize in advance if I mispronounce your name or components of your study. We're doing our best. All right, so we have a couple of abbreviations here for you that we'll use throughout our talk. Feel free to refer back to it as needed. And I'll kick us off by going over the lineup for our talk today. First objective, we'll talk about long-term impact of antihypertensive deprescribing. We'll stay in the cardiovascular theme and talk about deprescribing cardiovascular medications as a whole. We'll shift gears a little bit to talk about patient engagement in deprescribing and patient perspectives and how they might factor into deprescribing decisions. And then we'll talk a little bit about the utility of artificial intelligence, or AI, and helping support some of those deprescribing decisions that we might make. Now, our end goal for all of this is to hopefully eliminate public enemy number one, potentially inappropriate medications. And I'll kick us off on the ride today by describing the long-term impact of antihypertensive deprescribing. So if you've been with Amy and I from the get-go, you might remember that way back in 2020, we first presented the optimized trial here, and we've presented some subsequent iterations in the years following. So we'd be remiss if we didn't present the latest rendition to you here today. So in this rendition, the study authors are focusing on the effects of antihypertensive deprescribing on longer-term hospitalization and mortality. So this was a randomized, unblinded, non-inferiority study conducted in UK general practices. It included patients aged 80 and up with systolic blood pressures under 150, taking 2 or more antihypertensives. And here patients were randomized to either usual care or deprescribing of a single antihypertensive following the structured med reduction algorithm on the screen. Now, if you remember the outcomes from the original trial, which looked at outcomes at 12 weeks, the study authors found no significant difference in systolic blood pressure control or other clinical outcomes, despite a slightly increased systolic blood pressure amongst folks who had their antihypertensive deprescribed. So that was at 12 weeks. This rendition is looking at 3 or more years post-deprescribing. Is there a difference in time to all-cause mortality or hospitalization? What does the maintenance of deprescribing assignment look like? And what are subsequent blood pressure outcomes? In terms of patient demographics, at baseline, patients had a mean age in the mid-80s, not a ton of comorbidity or concomitant medication use, not a ton of cognitive impairment or functional impairment, so pretty healthy old cohort. And when we follow that cohort at about a median of 4 years of follow-up, about 90% of the original cohort was retained. Of those who had their antihypertensive medication deprescribed, or in this case, they call it the med reduction group, just over half of those patients who are alive at this follow-up time point still maintained their antihypertensive med reduction. In terms of primary outcome, there was no significant difference in all-cause hospitalization or mortality in either the intention to treat or the per protocol analyses. But you can see, right, amongst all of these groups, about 70% for all-cause hospitalization or mortality. So as we've gotten sort of beyond that, 85 to getting closer to 90, we're seeing some morbidity burden here. Now, we might expect, right, that the number of antihypertensives would be lower in the med reduction group, and that was true. But the study authors also found that the number of total prescribed meds was also lower amongst this antihypertensive deprescribing cohort. And there were no differences in blood pressure outcomes. So what this tells us is that after about 4 years of follow-up of deprescribing antihypertensives in these older adults who are potentially overtreated, we see that deprescribing in this case is not associated with loss of blood pressure control, doesn't appear to increase morbidity and mortality, and it does appear sustainable. So in this latest rendition of the optimized trial, hopefully we can lock this conclusion up that antihypertensive deprescribing is safe and sustainable.
Excellent. Thanks, Kristen, for starting us off this year. If you get to, so we're going to move from your antihypertensive deprescribing, we're going to move to a little bit broader, but stay within the idea of cardiovascular medications. You stuck with Optimize. I'm going to stick with a trio of studies take place in the VA. And these three, I'm going to try to present all together to show some of the overlap as the same study group. And they wanted to look at long-term care residents who are deprescribed or continued antihypertensive medications and the effects on cardiovascular event hospitalization, functional decline, and cognitive decline. So this takes place, VA long-term care, as I mentioned, October of 2006, so we're going a while back, until September of 2019. They use target trial emulation methods. So I am not a methodologist. Mike Steinman is a co-author on all these papers. You can hit him up after if you have more questions. But essentially, it is a way to use observational data and apply statistical methods to emulate, actually well named, the idea of a randomized clinical trial. In this case, the exposure is deprescribing, defined here as either complete cessation of that hypertensive med or at least a 30% reduction in the dose maintained for at least 2 weeks, to randomize the used inverse probability of treatment weighting. There were 3 studies, so we're going to talk about 3 different outcomes. First was MI and CVA events. The LU study looked at physical function based upon activities of daily living, and the Jing study used cognition based on the cognitive function scale. Now, they all did multivariable regression modeling. The functional study and the cognition study subsequently stratified the analyses by whether or not the long-term care residents had dementia at baseline. So we'll walk through the timeline a little bit. So a resident gets admitted to long-term care. They really want these to be long-term care stay. And so anyone who was there for less than 12 weeks was excluded. They then had an enrollment window. So for the cardiovascular disease outcomes, these are weekly enrollment windows where a subject was entered either into the deprescribing cohort or the continuation cohort. If in subsequent weeks they were still in the continuation cohort and then they moved into the deprescribing cohort, it was essentially 12 subsequent 12 trials. They aggregated all of those populations together for their analyses. The 2 other studies had a slightly simpler enrollment window. From weeks 13 to 16, if you entered the deprescribing cohort, you were then a deprescriber, otherwise you were a continuation. They were followed for about 2 years, censored if they left the long-term care facility, went to hospice, or died. The per protocol analyses, which I'm only going to be presenting the findings from per protocol analyses, also censored if they changed which group they were in. So if somebody had stopped the medicine and were considered in the deprescribing cohort, but then subsequently resumes that hypertension medicine, they now are censored out for their study. So the population overall I'm showing here is from the cardiovascular disease outcomes. It's the VA, so it is older men. Relatively well-controlled baseline blood pressures. About 18% were in the deprescribing cohort. Overall, 11% of the deprescribing cohort and about 9% of the not deprescribed or the continuation cohort ended up having that cardiovascular disease hospitalization. Is that different or not, though? So it's not. Looking on the left, you see the survival curves. On the right, I've put up the adjusted hazard ratio. And there's no significant difference in cardiovascular disease outcomes whether or not you stopped your blood pressure medicine. So we're going to move a little bit now to the function population. So similar baseline characteristics, you can see here, I've only put up the ADLs at baseline because it's relevant to this particular study. The enrollment window is different. So here there's 9% are in that deprescribing cohort. And At baseline, the deprescribing cohort did have slightly worse physical function based on their ADL score. So in terms of the outcomes, I'm going to walk us through. So first, over time, no matter which group you were in, your physical function gets worse. Bad news for everyone. But if we look at the effect of deprescribing on the decline in your physical function, the negative estimates there means that it actually slows down the worsening of your physical function. So good news for deprescribing, this is statistically significant among the residents who did not have dementia at baseline. Looking at the cognitive function population, here we again see 9%, very similar because again, the same enrollment windows. No differences in baseline cognitive function scores. And about 10 to 12% had a decrease in their cognitive function score over time, depending on the different groups. Again, is that different? Well, when we look at deprescribing and the effect on the decline in cognition, what we see here is, while just ever so slightly significant in the total population, this time the significance really shows up in the residents who have dementia at baseline. So we're going to pivot a little bit from the focus on hypertension that we've only talked about so far in this presentation and talk about aspirin use. Specifically, and this is also relevant to some of the talk that we heard earlier today, is this idea of initiating versus stopping. So this wanted to look at whether stopping aspirin that's being used for primary prevention for cardiovascular disease is beneficial or harmful. So the ESPRIT trial, as folks in this room probably are aware, looked at whether or not initiating low-dose aspirin was beneficial. And it found that it wasn't, and it increased harmful events such as major bleeding. And so it led to a huge change in our clinical practice about not starting aspirin for primary prevention. But what if somebody's already taking primary prevention aspirin? Is it worth stopping it if they haven't had any problems yet? And that's what this study wanted to do. Looking at data that was follow-up data from the ESPRIT trial. And they also used target trial emulation methods. So this time the aspirin deprescribing is the exposure. For their randomization strategy, they used propensity scores. And they had 4 outcomes: incident cardiovascular disease, major adverse cardiovascular events, all-cause mortality, and major bleeding. And they looked at these outcomes at 3, 6, 12, and 48 months after randomization. You can see the study population here. The thing that I really want to point out attention to is the difference here is 89% fall into the deprescribing group, so almost like the inverse of what we saw in the prior studies. Again, there was intention to treat and then per protocol analyses. I'm only going to talk about the per protocol findings. Did stopping aspirin for primary prevention have an impact? Well, if we look here, in terms of cardiovascular disease and major adverse cardiovascular events, there was no difference when stopping aspirin versus not. But looking at bleeding and mortality, at 3, 12, and 48 months, continuing aspirin was worse with respect to major bleeding. And at 12 months, continuing aspirin was worse in terms of mortality. Putting it together, we have more evidence that putting away heart medicines does not worsen morbidity, probably slows decline functionally in those without dementia, and functionally in those without dementia and cognitively in those with dementia. And rounding up that sidekick aspirin similarly seems to improve safety on our streets by reducing the risk of bloodshed.
Thanks, Amy, for rounding up those heart meds and getting them off the mean streets of Chicago. All right, so I will shift gears a little bit in our next objective, where we'll evaluate what happens when we give information or power to the people, or in this case, to patients. And so we'll evaluate the influence of patient engagement in deprescribing. And so we'll start off with this evaluation by Jones and colleagues, which sought to examine the impact of patient-directed educational intervention, aka Empower brochures, that'll be the theme for these next 3 studies, on clinician deprescribing of potentially inappropriate, low benefit, and potentially high-risk medications. So this was a pragmatic, multi-site, non-randomized clinical trial conducted at 3 distinct VA medical centers. And here, the intervention included mailing those medication-specific brochures, or Empower brochures, to eligible patients taking one of these 3 classes of meds, either taking PPIs, high-dose gabapentin greater than 1,800 milligrams per day, or patients on anti-diabetics who also had high risk of hypoglycemia. Now, these brochures were mailed in the 2 to 3 weeks before an already scheduled primary care provider visit, and these patients were compared to historical controls seen by the same PCPs in the year prior. And the primary outcome here was deprescribing, defined as total cessation of the med in question or a decrease in total daily dose in the 6 months following that primary care provider visit. So demographics here, pretty standard for an older VA population. And you can see the breakdown of medication group. PPIs were actually the largest representative medication group and gabapentin the smallest. So in terms of results, we see an overall increase in the rate of deprescribing in the intervention arm as compared to the control arm. And regardless of the intervention, there was a greater odds of deprescribing amongst patients taking gabapentin versus PPIs. So we're really seeing the impact of the Empower brochure here in the outpatient setting. Our next evaluation is going to look at Empower brochures in the inpatient setting, in the GABA-Y evaluation. And this sought to assess the impact of those Empower brochures on gabapentinoid deprescribing in particular, again, among inpatients. So this was a prospective pre-post study conducted on 5 medical units at McGill, and it included patients aged 60 and up who were receiving a gabapentinoid, so either gabapentin or pregabalin at the time of hospitalization. And patients received the Empower brochure, and clinicians on the wards received monthly educational sessions. They were super brief, like 5 or 10 minute orientation to like, what is the study? What is this brochure? What are the pros and cons of gabapentinoid deprescribing? And here, the primary outcome was deprescribing assessed at 8 weeks following discharge. And this was assessed by patient telephone interview and verified against a provincial drug database. Here, the definition of deprescribing was cessation of the medication or discontinuation, or a taper with an explicit intent to discontinue. Secondary outcomes included other medication changes, changes to global health, pain, and cognition. In terms of demographics, patients had a median age in the mid-70s, were largely living independently prior to admission, had a median length of stay of about 10 days. What I think is more interesting is looking at these total daily doses of gabapentin versus pregabalin. And if we compare this to the study on the outpatient side, the study by Jones and colleagues, where we saw that targeted patients taking gabapentin in doses of greater than 1,800 milligrams a day, we're seeing a relatively lower dose here of gabapentin. And obviously the inclusion of pregabalin in this evaluation, which the Jones and colleagues study did not include. In terms of outcomes, the study authors did see an increase in deprescribing amongst the the intervention arm. So showing us that these Empower brochures can also work in the inpatient setting. So now what if we target specific categories or characteristics of patients with these Empower brochures? And so we'll shift gears now to talk about the Deprescribe AD trial, which sought to evaluate the effect of a patient and or prescriber mailed Empower brochure on potentially inappropriate prescribing in patients specifically who had Alzheimer's dementia and related dementias. And so this was a prospective, open-label, pragmatic, randomized clinical trial, importantly here, embedded in 2 large major health plans. And this included patients aged 50 and up, taking one of the 3 potentially inappropriate meds listed here, who had Alzheimer's disease or related dementias, and had used these meds in the prior 3 months. Now, patients, even if they were taking multiple of these drugs, were only included once, and they stacked it to make sure that patients who were taking antipsychotics were given priority in order of 1 through 3 here. So this study had 3 major arms. The first was the mailing of the brochure to the patient who had Alzheimer's or related dementia, and the most recent prescribing clinician. And so that's also important. It's not necessarily the primary care provider here, it's the most recent prescribing clinician. The second arm, the brochure was mailed just to the most recent prescribing clinician, and third arm, obviously usual care. So following this intervention, there was a 3-month period that was really kind of considered this blackout window or blackout period for primary outcome assessment. And that was to allow people to receive and open their mail, right? For folks to use up any remaining supply of medication. If something's on auto refill, use it up before the following 6-month window for deprescribing outcome assessment. And so from a demographic perspective, probably not super surprising that this cohort had a pretty high burden of comorbidity and polypharmacy, given that it's a dementia group. And you can see the breakdown of drug classes that were ultimately included here. So spoiler alert, we didn't see any significant effect of this health plan initiated mailing to patients who had Alzheimer's disease and related dementias on prescribing of these drug classes. I still think that sort of taking all of this together, giving patients information, really helps to put medication use kind of under a magnifying glass and help raise suspicion amongst patients about the meds that they're taking. And so we see also the efficacy of these Empower brochures in multiple settings, but there might be some illusion here that that effect might depend on who is the recipient of the brochure, what are their characteristics, who is sending that brochure, and the timing of the patient or the clinician potentially receiving that brochure. So I'm going to stay in this theme of sort of patients, information, and perspectives, and we'll talk a little bit about how we might account for patient perspectives in the deprescribing decisions that we might be making. And we're going to do that by piggybacking on the trial by Jones and colleagues, right, which looked at Empower brochures amongst veterans in primary care. So this evaluation examined the impact of those same brochures, but on deprescribing discussions and patient engagement. So this was a survey of the patient experience following that intervention. And the primary outcome here was patient-reported deprescribing discussion as assessed on a post-visit survey. So in terms of patient characteristics of the respondents to this survey, maybe not super surprising that most respondents had pretty good adequate health literacy. When we look at the impact of their brochure, there's really kind of 3 buckets of ultimate impact. Number 1, patients largely engaged with the brochure, and they either read it and did the activities, or contacted their healthcare provider. The second thing the brochure did was it got patients concerned about the medication in question. And it also spurred about 1/3 of patients to have a deprescribing discussion with their primary care provider. And I think the most important thing here is that patients initiated the majority of those discussions. So here we're really seeing the impact of those brochures from the patient perspective. And when we look at the factors associated with an increased odds of deprescribing or having a deprescribing discussion, amongst respondents, it was patients who were taking a PPI, who were taking gabapentin, versus those taking an antidiabetic, greater brochure engagement and discussing the brochure with others or contacting their PCP prior to the appointment. So probably not super surprising. The more engagement you have, the more likely you are to have a deprescribing discussion.
Excellent. Thanks, Kristen. I'm going to pick up and actually highlight a bit more on that top one here. So interestingly, the diabetes patients were less likely to ask about stopping their medications. So how can we think about patient-reported perspectives about deprescribing on subsequent actual deprescribing of diabetes medicines? And so this study is very much focused on that. It was a survey using the Diabetes Preferences and Self-Care Survey back in 2019. And there were 3 items that they used as their primary questions and exposure. So the first was about, I expect to need prescription medication for my diabetes for the rest of my life. I would be willing to take less medicine for my diabetes. And then the last question was, in the future, do you expect to take more, the same, or less diabetes medication? Their outcome for deprescribing was a little different than what we've been talking about pretty much all morning. So the first 2 items, discontinuation or a reduction in the daily dose, is pretty common for what we've been seeing. But reduction in the frequency of daily dosing and in the total daily pill count also qualified in the study as deprescribing. They had 2-year follow-up, and they did separate regression models for each of the exposures of interest. There were about 1,600 subjects. In terms of their demographics, nothing all that notable to point out, but from a clinical perspective, 29% would be considered overtreated based on the Endocrine Society guidelines. Further, 25% were considered to be at risk for hypoglycemia. So what were some of the perspectives of these survey respondents? The majority did expect that they would need to take medicines for the rest of their life, but just over half were willing to take less medicines. Perhaps most interesting, I think, is that 90% could identify a risk of stopping their medicine, but only 65% could identify a benefit to taking less medications. So it's a really skewed perspective about what stopping medicine would mean. In terms of the outcome, we wanted to see how much deprescribing happened in this population, 38% overall, of whom 24% had all of their diabetes meds completely stopped. But let's look at some of the clinical factors, not the belief factors yet, we'll get there, but just the clinical factors that were associated with deprescribing in the subsequent 2 years. So things that were associated and that had the highest magnitude of effect included older age, and we're talking older age here, and poor health status. Additionally, being a woman, limited life expectancy, falls, and worse kidney disease. Not associated, and as clinicians, I'm like, what are we doing here? A history of polypharmacy, having severe hypoglycemia, and being overtreated per Endocrine Society guidelines were not associated with subsequent deprescribing in this study. What about those belief factors? So the thing that was associated was not expecting to need diabetes meds for the rest of your life. And the magnitude of effect here is on par with those clinical factors that we saw on the prior slide. Things that were not associated, though, with subsequent deprescribing was an expectation to take less medicine and a willingness to take less medicine. So even if they wanted to, it didn't seem to be associated with future deprescribing. So how do we think about what might get people to want to take, to deprescribe more, to recognize harms of staying on a medicine and benefits of deprescribing? So Vordenberg and colleagues did just that by exploring the degree to which providing patients warning information about when starting a medicine would impact subsequent interest in discontinuing it. So this was an online survey at the end of 2023, beginning of 2024. They had 4 hypothetical vignettes. So it was really one vignette around a proton pump inhibitor that had 2 variables that they switched depending on which vignette you were assigned to. The first variable was whether or not the starting scenario included a warning about long-term use. And the second was whether or not that proton pump inhibitor was available over the counter or was prescribed. They then, at the time of this initiation in this hypothetical scenario, asked respondents to report how helpful and how risky it would be to start a PPI. The vignette then continues on for a hypothetical year, and the respondents are then asked how much interest they had in stopping their PPI. So about 1,200 individuals in the survey population in relatively good health and relatively competent in filling out medical forms. At initiation, factors that were associated with considering a proton pump inhibitor to be helpful was the lack of a warning about long-term use, availability as a prescription, higher education, and, perhaps not surprising, respondents who are current PPI users. On the flip side, things that were associated with perceiving that PPI to be risky included the inclusion of a warning, over-the-counter availability, and the respondent was a prior or never PPI user. Let's fast forward a hypothetical year. And what did they want to do? The majority still did, on the right-hand side, you can see, want to stop that proton pump inhibitor. And what are some of the factors that were associated with wanting to stop it after 1 year? The ones of interest to this study, so not significance, was over-the-counter versus prescription status. However, probably the most important is that including that warning about long-term use at the time of initiating the medicine was associated with an increased likelihood that they would want to stop it after 1 year. So this idea of starting versus continuing is, we've been talking about earlier today, a little bit here now. And so they're different concepts. And so to quantify that, Chaytoff and colleagues wanted to calculate out the pill disutility associated with starting versus continuing a medicine for cardiovascular disease prevention. It was an online survey that used time trade-off methods. So they asked respondents, how much time are you willing to give up of your life to not take a medicine, but yet you still get all of the benefits? And that could range anywhere from no time at all the way up until 5 years. They also asked respondents to essentially predict how many more years of life they had. And then they calculated out pill disutility as the amount of time willing to give up over projected years remaining. The respondents were either answered the continuing scenario or the starting scenario. They thought it would be too complicated to try to get people cognitively to think about both. And 85% of respondents are medication takers. And about 12% also have a history of cardiovascular disease. And again, this was a question about not taking a medicine for cardiovascular disease prevention. So thinking about who your respondents are here. Which kind of rings true. All the way on the left is the 0 time. Most people were not willing to give up any years of life, any months, anything, in order to not take a pill. But it's not exactly the same. The red bars are the continuing scenario, the gray bars are the starting scenario. And if we calculate out the pill disutility, it was higher in those in the initiating scenario than in the continuing scenario. So putting together the patient's voice here, we can see that educational materials can really shake up beliefs, and that views about the need for medication can influence deprescribing as much as clinical factors. Sharing safety information upfront when initiating that prescription or medication over the counter can impact subsequent interest in actual deprescribing. And continuing a medicine isn't seen as bad as starting a new one. So we may need to leverage a little bit more that time when we are initiating medicines.
Hear ye, read all about it. The pills are bad, I guess. Thanks. All right. Well, so now that we've seen this kind of groundswell of like patient engagement, patient empowerment, patient perspectives, can we kind of bulk up our fighting force to take down public enemy number one by using AI or artificial intelligence to help us make some of these deprescribing decisions? Let's see. So the first evaluation we'll talk about today compared healthcare providers and AI chatbots, in this case, ChatGPT, actually in both cases that we'll talk about today, ChatGPT, and making deprescribing decisions for patients specifically taking benzodiazepines. So this evaluation actually used cases derived from real patients enrolled in the Euroageism H2020 study. So it's 154 cases, and these were community dwelling, older adults living in Croatia taking a benzodiazepine. And here the study authors wanted to assess and compare healthcare providers and ChatGPT in terms of deprescribing recommendation rate, AI's subsequent percentage certainty in its decision, and comparing the categorization of the deprescribing criteria, or essentially rationale for deprescribing. So for healthcare providers, they were provided these cases, and they were provided with these 4 categories or criteria rationale for deprescribing, and asked whether they'd consider deprescribing the benzodiazepine, and if so, in which of these categories. To simulate this with ChatGPT-4, the study authors developed a standardized prompt in which they could insert each of those cases to see what it spit out in those sort of same exact outcome endpoints. So in terms of results, the overall rate of deprescribing and the subsequent agreement about deprescribing among cases was high, but the kappa value here is relatively low. And so that tells us that that agreement could actually be due to chance. In addition, the study authors make note that 22% of these AI outputs were either ambiguous, generic, or totally inaccurate. They give a really great little vignette in the paper about multiple benzodiazepine use, like the most obvious opportunity for deprescribing, right? People using 2 benzos. Healthcare providers identified 23 cases of multiple benzodiazepine use out of the 154. The AI chatbot only identified 1 case of duplicative benzo use amongst these patients. So we've seen kind of what this looks like in benzodiazepine use and how it compares to HCPs. The next evaluation by Rao and colleagues sought to evaluate ChatGPT's deprescribing decisions in standardized clinical vignettes of patients with polypharmacy. So how does it stack up? So this was more of a qualitative analysis of ChatGPT's deprescribing decisions. And they used essentially one base case in which the patient was taking 7 total medications. And they modified that base case into 3 vignettes in which the patient had varying degrees of functional dependence. And then they included an additional question like, what would you do if this patient did or didn't have cardiovascular disease? Essentially to introduce those 2 variables of function and cardiovascular disease. And the outcomes here were binary deprescribing recommendations made by the chatbot, the number of medications deprescribed per scenario, qualitative influencers of that decision making, and really importantly here, the variance in technical replicates, right? So if I take the same exact prompt and put it in ChatGPT a bunch of times, every single time, in theory, right, I should get essentially the same response from ChatGPT. Well, we'll find out. A little foreshadowing there. So in all of these cases, out of the 7 meds in the base case, ChatGPT pretty consistently recommended deprescribing about 3 meds, and it was able to sort of factor in cardiovascular disease and function to varying degrees. What's most important is the degree of variance seen across those technical replicates. So it was not identical responses every time the identical prompt was put into ChatGPT. So that tells us that there's probably some flaw or inconsistency in the logic that ChatGPT is using to make these deprescribing decisions. So ultimately, AI chatbots, or specifically ChatGPT, at least in these evaluations, can factor in some things, right? But it's pretty inconsistent. So at this point, it might have some potential more in decision support and not so much decision making. So it does have this potential, but likely requires significant supervision. So that might mean a clinician double check. That might mean turning down the temperature associated with the chatbot. It might mean putting really tight constraints in the form of a system message into the chatbot in order to try to reduce the potential for error here. So while we'd really love to build up our fighting force and get some help here from AI and putting these sort of bad meds away, all in all, really, AI still remains a rookie. It has not quite earned its badge yet.
So we hope that the literature that we've reviewed today has really helped us to go through and understand the long-term impact of antihypertensive prescribing and as well as cardiovascular meds overall. Talked a little bit about the influence of patient engagement and how we can integrate patient perspectives. Ended a bit here with the potential and not quite there yet role of AI in deprescribing, and hopefully altogether, this helps us eliminate public enemy number 1. So we are happy to wrap up now and open it up for any discussion or comments. Also, you are welcome to make your own mugshots later on at our photo booth.
And props are included and encouraged. So if you do utilize the lineup photo booth to put the bad meds away, please be sure to tag everybody on socials and, give us a copy of your picture. We'd love to see it. Any questions? I know everybody's really hungry for lunch, and it smells delicious out there. So, yeah.
So that was fantastic. I didn't need to say that. What do you guys think?
I'll pay you for that one later, after that compliment.
What do you think is the mechanism by which the efficacy of antihypertensives decreases over time? Meaning, when an antihypertensive gets started, you typically expect 7, maybe 8. Guys, am I right on this? Decrease in systolic blood pressure, depending upon that. And yet withdrawal was only 3.5. Is there an adaptation that we need to know and maybe be cognizant of?
Yeah, I mean, I think it's a good question. I don't know that I have like some magic 8-ball answer. It probably has something to do with some level of homeostenosis occurring, with age or, over time, or potential adaptation would be my best guess. It's sort of hard to know exactly what it might be, drug to drug or patient to patient, but my best guess would be some form of homeostasis over time.
An antihypertensive drug, independent of what drug it was. Okay.
Yes, and so if you and we can go back in time, right, to look at the different classes of medications. They generally follow the sort of structured algorithm. And sort of a couple years ago, 2023, we had presented the evaluation that really broke down the outcomes associated with each of those different medications that were deprescribed. And the sort of take home there was like, keep the CCB for last. Like if anything should kind of stay on the list, it should probably be the CCB in terms of being like the most effective and having sort of the greatest risk of blood pressure increases following discontinuation.
Thank you.
Yeah, of course.
I have a question about the direct-to-patient mailings, like the Empower-like interventions. Do you feel that the study designs have any impact on the outcomes? For example, like the presence of an attention control group or the lack of. How does that potentially play into the differences that we're seeing?
I'm going to fence this to you. So if you noticed, Dr. Linsky was on some of those papers by Jones and colleagues and Pendergast and colleagues. So even though I presented them, she's a true expert. So I'm going to punt this one over to you.
That's fine. You took the pharmacokinetics, pharmacodynamics one. So I think there is probably the way the delivery probably does matter. That's where there's now the interest in the setting where it's happening, inpatient, outpatient, whether it's the individual themselves. For us, for the study that I was working on, we were very intentional about wanting it to be by snail mail and not being given out in the waiting room right at the time of, because these are 12-page brochures. They take time to read through and actually think about, and we didn't want it to be just another one of the papers you got when you walk in and sign away, like whatever. So there is probably something around medication education that is just that, but the original Empower brochures, they were developed with a lot of rigor in terms of thinking about adult learning and cognitive dissonance, and really, they're meant to create some concern as opposed to just learn more about your medicines. And so that was, I think, the bigger difference. And so a lot of the studies that have compared it to a different group is either nothing or some sort of educational thing, which may or may not be the exact same.
Yeah. Mm. Yeah.
So how do we, first of all, have to know why? How do we train the algorithm better in a way that we can test it?
Yeah. Yeah, it's a great question. So
Could you
for
try to
those who might
repeat-
not have
yeah,
heard,
thank
the
you.
question was about AI chatbots and large language models, and how do we put some more constraints in place to enhance some of the rigor and consistency around the logic that might be used. And I am no supreme expert on all things AI, but some of the things that we've played around with and some of our AI chatbots are changing the temperature so that there's less liberalness in how the chatbot responds. You can create a system message and very specific inputs that the chatbot is querying to make that response, to try to reduce the amount of variation that's present in those responses. And there's pros and cons to that, right? So you're making sure that for lack of a better term, internal validity of the response is really strong, but it might not be able to assess some types of questions or some types of scenarios if it's not a part of the sort of base database or crafted in the system message. So I think there's still a lot happening in this space about how do we do exactly that. I know there's some sessions here at AGS this week that are looking at AI in research and in the clinical space and how we might do some of that. So hopefully that answers your question.
Thank you so much for a really great presentation. I have several questions. So I have one in particular in relation to something I'm seeing more and more consistent in my clinical practice. with Medicare Advantage particularly, the number of now nurses or APRNs who are going to patients' homes to be able to do MedRec, upcoding in some ways, but also kind of this opportunity to play a role in intervening on polypharmacy and potentially deprescribing. Oftentimes that's communicated to the primary care clinician and saying, like, we did a review of your patient's meds, and here are some recommendations. And sometimes, depending on the plan, I have to actually like sign off on certain recommendations. For Medicare, also, even traditionally, if patients have a certain number of conditions and above, they are eligible for like home visits around this. So I'm curious in terms of thinking about the brochures, a kind of passive form of education, but if there's been studies or thoughts about like coupling, even though it's coming from a health plan that might have different motivations, how those sorts of passive methods might be coupled with these health plans towards deprescribe, or if there's been any mitigation.
Your question makes total sense. I think, you're thinking about it from the perspective of the health plan, right? And in the evaluation, the Deprescribe AD, I mean, was it that because the patients had dementia? Was it because it was the prescribing clinician, not the PCP? Or was it because it came from the health plan, right? And like, how often do patients get like, your formulary is changing, like you can't get this albuterol version, you gotta get this one, right? And patients are like, yeah, whatever, right? And so was it because it was mailed passively from the health plan versus in the scenario you're talking about with home visits and the Medicare Advantage, that's a human element, right? And so would that be different if that health plan and that intervention had that humanistic element of that sort of one-on-one ability to communicate and to actually make sure that your intervention was received? I mean, I would intuit that you would see a different response, but that would be a guess. I don't know if that's been examined.
Perhaps, though. The only thing that I would add to that is we did this within the VA, right? And so the VA is essentially a health plan.
Right.
And you could also even argue that if you're talking about stopping something, that people may feel that, oh, this is something that I earned, that I deserve, why is it being withheld from me? And so it was successful even within that context, that I don't know if it's the health plan as much. I would argue that the recipient may have also had a big role in this one. To the best of my knowledge, I have not seen published studies looking at there may be studies that have looked at like home-based primary care and a little bit more of the clinicians going in. I don't know about in terms of more on that team-based aspect, although I think that's a great idea to pursue. But I think that's still something to evaluate.
Yeah, thank you.
All right, we're getting our signal as well.
Yay!